We described the PK/PD properties of antibiotics used for C. diff infections. Now, let's identify risk factors for the development of new onset and recurrent C. diff infection. The IDSA guidelines require two things for the C. diff infection case: the presence of diarrhea or evidence of megacolon or severe ileus, and either a positive laboratory diagnostic test result or evidence of pseudomembranes demonstrated by endoscopy or histopathology. Recurrent C. diff infection is defined as repeated episodes within 2 to 8 weeks of the previous episode of C. diff infection. So repeat infection after 8 weeks is actually considered new episode C. diff infection. Let's take a look at the effect of antibiotics on the normal gut flora. In healthy patients with no risk factors for C. diff infection, the gut flora includes both a high quantity of bacteria as well as a high diversity, represented by the red graph. Now, if someone takes antibiotics in this blue, represented in the blue zone here, the quantity and diversity of normal flora will drop, which will place the patient at the risk of getting C. diff infection. And of course, the C. diff strains that are resistant to whatever antibiotic that was used actually have selective advantage in this disrupted flora. Of course, these are antibiotics used for other infections such as pneumonia. Now, once the treatment of antibiotic for whatever infection is done, then there is a period of no antibiotic. This allows for the normal flora to return to the normal state. Now, as the normal flora is restored, then the risk of C. diff goes back down to the level that there will be no risk for C. diff infection. Now, when antibiotics are discontinued in patients, the time that it takes for flora to return to normal state is very variable and it takes a long time. Therefore, there is a gap between this because of variability in patients. It often takes several months for the flora to return to normal state. Let's look at risk factors for new onset C. diff infection. Antibiotic usage, as I explained, is a huge risk factor for C. diff infection, so is age greater than 65 years. About 94% of all C. diff infection cases have a recent healthcare exposure, so recent hospitalization is a risk factor, as well as VRE colonization. So patients who receive antibiotic are more likely to have vancomycin-resistant enterococcus colonize the GI tract. So this makes sense that people who have VRE, in fact, about half of the patients with C. diff infection often have VRE colonization. Other risk factors include receipt of chemotherapy, immune compromise or neutropenia, feeding tube, residence in nursing home, chronic kidney disease, and something that's a bit controversial is the receipt of proton pump inhibitors. In observational studies, proton pump inhibitors have been associated with C. diff infection. In fact, more so than histamine 2 receptor antagonists. And this association is typically in chronic use of PPI. So typically, patients who are on a PPI for more than 28 days are at increased risk of C. diff infection. And this may be more of a biomarker. So someone who's receiving PPI chronically might have other comorbidities that are more likely to expose them to C. diff infection rather than the acid suppression itself leading to C. diff infection. Because as we know, Clostridioides difficile can present as spores, and spores are actually stable to the acidic environment. So whether the acids are inhibited or not is not really going to have an impact, have a direct impact on C. diff infection, but this is an association to increased risk of C. diff infection. Things that manipulate the GI tract, such as feeding tube, gastrointestinal surgery, are considered risk factor for C. diff infection because they can disturb the flora. Now let's talk about the elephant in the room, antibiotic usage. The highest risk of C. diff infection is during receipt of antibiotics and in the first month after finishing the antibiotic. And we're talking about antibiotics for other indications such as urinary tract infections or bacteremia. Now, this risk can continue to exist up to 3 months after cessation of antibiotics, and it is dose dependent. That's associated with increasing cumulative antibiotic dose, so the higher the dose, the higher the risk, as well as increasing number of antibiotics, so combination therapy, higher risk than a monotherapy with antibiotics, and of course increasing number of days of antibiotic exposure. So every single day of antibiotics will increase the risk of C. diff infection. So the sooner we can discontinue antibiotics, the better it is in protecting the patients from getting C. diff infection. Now, certain antibiotics have higher risk of antibiotics. In general, pretty much every antibiotic has been associated with C. diff infection because one way or another they have the propensity to disturb flora, but some antibiotics significantly more than others. So you can see that on the top of the list, we have clindamycin, which has been historically associated with one of the highest rates of C. diff infection, along with cephalosporins, fluoroquinolones, carbapenems, penicillins, and this includes penicillins combined with beta-lactamase inhibitors such as piperacillin tazobactam, as well as combination therapy. So if you combine multiple antibiotics, for example, when you do empiric treatment. Now, at the same time, there are certain antibiotics that have low risk of antibiotics. And at the top of the list is tetracycline. Specifically, doxycycline has been shown to have very low risk of antibiotics. And some studies have even suggested that doxycycline might protect from getting C. diff infection. Other antibiotics with low risk include glycopeptides, oxazolidinones such as linezolid, metronidazole, nitrofurantoin, and trimethoprim sulfamethoxazole or Bactrim. Let's talk about risk factors for recurrent C. diff infection. About a quarter of patients will actually have recurrent C. diff infection after the first episode. You will immediately see that risk factors for recurrence basically are the same risk factors as getting the first episode of C. diff infection, such as advanced age and receipt of antibiotics. And the patient's immune system plays a role here. So when we give antibiotics to a patient which will disrupt the normal flora, the patient will be at risk of getting toxigenic Clostridioides difficile. And then inside the patient, the bacteria will start toxin production. And then once the toxin is produced, then the immune system can actually respond. So if the patient has sufficient immune response, meaning that the body will actually have antibodies against the toxin, so antitoxin response, this patient will actually be asymptomatic carrier. Now, if the patient has inadequate immune response, these patients will have symptoms including complications such as colitis. And then if this inadequate immune response continues, that's when these patients will have recurrence of C. diff infection. Now, it is possible for someone who had delayed immune response, they might have a first episode of C. diff infection, and then in time they can have immune response and their body will have antitoxin antibodies, and then they will have resolution. So that explains why even with these patients who have recurrence after the first episode, pretty much 60% will have cure. These are the patients that had delayed immune response, and then there are about 40% of patients that just don't have immune response, so they will continue to have recurrence C. diff infection. So it's important to note that recurrence is not thought to reflect an antimicrobial failure, but rather is a failure of the host to either reconstitute his or her microbiota to establish colonization prevention, or failure of the host to develop a protective antitoxin antibody immune response during the initial infection, or both. It also makes sense that advanced age is a risk factor because advanced age is associated with low antitoxin B antibody. In fact, antitoxin B titers at baseline and at week 4 correlate inversely with recurrent C. diff infection in studies.